Welcome back. We did this briefly yesterday. We started a little convo about menopause, and the audio wasn't amazing. So I'm here with Dr. Hauschka again. She was sweet enough to meet with me twice on a weekend to talk
Of
about
course.
menopause.
Of course.
So to start us off, introduce yourself, I guess, if that's
Yeah.
okay. Okay.
Yeah. I'm Jennie Hauschka. I am a board certified OBGYN and have been practicing in the Charlotte, North Carolina area for almost 20 years. I did my residency here from 2006 to 2010, and then have been in a couple different private practices since then. My practice now has sort of evolved and grown with me and turned into more perimenopause, menopause. Actually, I still do lots of adolescent health and things like that. So I'm kind of seeing aging women, but also their teenage daughters. That's probably the most common combination I have.
I know, and it's crazy to think that I feel like I'm 17, but I'm a part of the aging woman population because I'm 40.
Terrible. I know. I
It's
know.
crazy. I don't know when it happens. So, to start us then deep in the convo of menopause, we'll go back. Yesterday we touched on it, but I think we should circle back because, like I said, the audio wasn't the best. And we're going to upload this so people can listen on their drive in to work or driving around town because menopause is confusing. And I think whenever you're
It is.
sifting through information on social media, it's hard to know. And I think people are embarrassed. So, to ask the question that I'll just ask you, what is menopause?
Menopause is actually just a moment in time at which you have not had a period for a year. And that definition makes it a little bit difficult sometimes because it doesn't really take into account each particular woman. So we can use that in addition to blood work that sort of leans us toward menopause being the diagnosis, but technically it's the moment in time when you reach no period for a year. So before that, you're perimenopausal. Before that, you're premenopausal. And after that, some people say I'm just menopausal or postmenopausal. They mean the same thing.
Okay. So changes in your hormones.
Yeah, the physiology and the hormone pathway between our brain, our pituitary gland, and our ovaries becomes disrupted. And that's mainly because the ovaries over time have fewer and fewer eggs or oocytes within them. Those are really what make most of our estrogen. And when those start to go away or wear out or whatever, then or they fail early from an autoimmune disease or from cancer treatment or lots of different things, having to have them removed for abnormalities or cancer or whatever. When they're no longer producing estrogen, our brain is not getting that same feedback. And because it's not getting that feedback, it's pumping out lots of follicle stimulating hormone or FSH. If you've ever had your hormones checked, FSH is one of the things we usually check. It's a great marker for fertility, but it's also helps us know if somebody's perimenopausal, menopausal, especially if we don't have the period to go by.
Follicular stimulating hormone
That's
okay,
right. Follicle stimulating hormone. Yep. Follicle
follicle
stimulating hormone.
stimulating hormone. So your
Mhm.
body is that so a woman if she gets her labs checked and her FSH is really high, she would assume.
That you're menopausal, but that can also get a little bit tricky. Like everything in medicine, there's no, right or wrong, black and white kind of thing. You can have premature ovarian insufficiency, and your FSH can go really high, higher than a typical menopausal woman would. But those women will sometimes have resumption of ovarian function. So once it's high, for some people, it doesn't stay high forever. But once you've gone through natural menopause, which happens around age 51, then that FSH level typically goes up and stays up. Certain hormones can bring it back down, but generally speaking, that's what happens.
So someone would begin probably to have symptoms maybe before, right? And so that
Yeah.
might prompt them to see because I think the leading question would be, what are the most common symptoms of menopause? Does everybody have the same classic symptoms that we know of? Hot flashes.
They do, but it's such a variety amongst different people and differences in severity. So you can look at labs, and this is kind of the challenging thing with getting labs on people is you can look at labs and they look normal in the perimenopause, even late perimenopause time, but it really doesn't tell you what is happening day to day, week to week, and cycle to cycle. So it can help us know, okay, this person has very low levels of estrogen and progesterone, her FSH is very high. That's easy. She's menopausal. But everything leading up to that is a little bit more tricky. And so you have to sort of take the context of labs with the context of the symptoms people experiencing. And perimenopause, the first symptom is usually menstrual changes, whether that's heavier, the period is lighter, it's spaced further apart, it's coming closer together. Any menstrual changes that are happening, late 30s, early 40s could be a result of going into perimenopause. And perimenopause can start 8 to 10 years before menopause happens. So there is a long period of time where we deal with these symptoms, and it can be really challenging for patients and for physicians because there's really no rhyme or reason to how these hormones are fluctuating. It's completely unpredictable. And so you have to kind of encourage patients to keep track of their symptoms. And to be honest, most women are very in tune with their body. If they just come in and tell me what's going on, I can kind of figure out where they are just by them telling me what's going on in their body. Sometimes people
Wow.
come in and they're just like, I just don't feel right. Um, the antidepressant I've been on since I had my third kid doesn't work anymore. My period is super heavy and now I'm tired all the time. um, Other things that I hear are my libido is totally shot. Um, it's usually not the hot flashes that happen first. It's some of these more subtle things that can take a little bit of listening and, just taking a little bit of extra time with people to figure out number one, what are the symptoms? Number two, which ones are most bothersome to you? Like, what do we need to try and tackle immediately? And then what's our plan going to be going forward, knowing this can be a pretty tumultuous time?
Right. And the timing seems to make a difference. And what's wild to me, and after I posted this yesterday, I posted a little sneak peek of us practicing this, and we covered a lot of things that resonated with people, much of
we
which we'll
covered a
reach.
lot of we covered a lot of topics, but we didn't really go in depth on any one thing. And I think especially perimenopause deserves that because it's important for people to know it's different for every person. And the length of time it lasts is different. How severe it is or how bad they feel is different. And so it takes, seeing, understanding, having some awareness around the fact that, okay, maybe this is something that's changing in my body. Maybe it is hormonal, but it also may not be all the hormones we typically think about. For instance, cortisol levels go up. If you have teenagers that are new drivers and they're out until midnight, or you're not sleeping very well, cortisol levels are going to increase. And when cortisol levels increase and sleep deprivation increases, you can get a lot of the same symptoms, especially mood changes and irritability. So it's kind of figuring out like what does her life look like right now? What is going on for her? And is this a more of a result of her life and life stressors or hormones, or like it usually is? It's both. It's
A
everything.
combo.
It's everything.
A combo.
Yeah, so perimenopause can feel like playing whack-a-mole with the symptoms. Like once we get one under control, something else comes up and something else comes up. And women, I think, don't realize the importance of taking care of themselves. When we enter perimenopause, Many women who have children have been dealing with little kids, which is extremely stressful and a huge mental and physical and emotional burden. And then they get to the perimenopause age and their kids are getting to that like asshole adolescent phase and teenager phase, and it can be very difficult to deal with that. Women who choose not to have children may be at a time in their career when they're expected to kind of climb the ladder and take on more and more work and more roles. And they feel like they can't handle as much stress and responsibility at work as they used to. So it really, I've had patients come in and say, I think I'm going to have to quit my job. I can't do this job anymore. Like it's too hard. I can't focus. I like cry at a meeting. And it's really not a flaw. It's because these hormone fluctuations affect every single tissue in our body and it's different for each woman.
Which I'm sure makes so many women, and why so many women love you. And I know you can't be everyone's doctor, but that is why I wanted to share you with the world, because for women to feel validated, to know that it's not you. It's not something that you just woke up
Right.
one day and think, well, you don't have the same resilience that you once did, but that it's truly chemical and totally
Yeah.
out of your control unless you have someone that understands. And so,
And sometimes it's really slow and insidious. Like you don't even realize how much is changing until you get to a point where you're like, oh my God, I have felt horrible for 6 months. You think, okay, maybe
Mhm.
it's just this period is irregular. I'm a little more moody before my cycle, or I'm just in a more stressful time. And once I get through this deadline or whatever it is, it'll get better. And it just doesn't. And that's when we need to start looking for other reasons.
And looking into the timing of things is hard
Right.
for people, because for me, I'm 40. I talked to a woman after we posted this yesterday, and she's in her mid 40s and she's already on estrogen. And so when I share this with people, or
Hmm.
like whenever I posted this, people were astounded that so many women are already on hormone therapy.
Yeah.
So can you talk a little bit about well, okay, I'll cut this out. When is the ideal time to start hormone therapy? And does timing even matter?
Timing matters a lot. So, once a patient is menopausal, so we're to the point where we don't have much in the way of ovarian function, their period has stopped. Usually, that's around the time that significant, or even a year or two before, that the significant hot flashes, night sweats, and all of that starts. We know from the plethora of data in postmenopausal or menopausal women that starting hormone replacement therapy within the first 10 years of menopause is the best and safest window. And I would argue that starting it at the onset of menopause is a really great idea for the reasons we discussed yesterday with respect to bone health. We did not realize until relatively recently the impact that perimenopause has on bone health. And now we're seeing a lot more patients that have awareness around that, and we're seeing the implications of it. So, going on hormone replacement on the early side is really not a bad idea, but it's not something that you would just start just because you're 48 or just because you're 45. We start it based on what symptoms a patient's having. So, and it doesn't impact everyone the same. Not everyone has an amazing treatment response. We have to do a lot of tweaking with it. And so I bring patients back about every 3 months and we say, okay, what's better, what's not, what's the same, what do we need to work on now? It's an evolving thing, and it can take some tweaking and some trial and error before we get them to their sweet spot.
So it is okay for someone. So like me, I'm 40, I started it, and I was able to start at the doses, and we can talk a little bit about this.
Yeah.
The dosing for hormone therapy is very different, although it is similar hormones, correct, as
Yes.
what's used in contraceptive pills. It is not contraception because they're not at the same doses. And so
Right.
it can cause bleeding in people that still have a uterus. So even though they may feel better taking the hormones, it would disrupt their life if they still had a uterus because they would be bleeding.
Exactly.
Okay.
Exactly. Yeah, hormone replacement therapy doses are not enough to suppress ovulation. That's how birth control pills, the patch, the ring, the shot, that's how those all work. IUDs work in a different way, so they do not impact ovulation. But the birth control pill dosing is, depending on the birth control pill, it's anywhere from 3 or 4 times to 10 times higher than the dose of hormone replacement therapy. And then you have the other complicating thing and confusing thing about it, which is what's bioidentical and what's not. And should I be taking synthetic hormones or not in perimenopause and menopause? So that's a lot of times part of the discussion that I'll have with patients when I talk to them about various treatment options. Because when I look at a patient in perimenopause, if bleeding is her primary complaint and menstrual changes, then I'm going to focus on that and maybe put her on a birth control pill for a while as her perimenopause hormone replacement. But once she gets, and if that helps with her symptoms, great. And once she gets to the natural age of menopause, we just transition her immediately over to hormone replacement therapy at that point. Or if the abnormal bleeding patient wants to do hormone replacement, I'll encourage her to get an IUD to treat the bleeding, or we use a different type of progesterone as opposed to the typical kind that we would start so that it controls bleeding better than what the micronized progesterone that we typically give for menopause hormone therapy will do for bleeding. So it's kind of a nuanced discussion, and it just depends on what symptoms the patient's experiencing as to like what we decide we're going to tackle first. But I think one of the dilemmas is that there are some things that are better symptom control and some things that are better bleeding control, and they don't always overlap, unfortunately.
Interesting. So some symptoms are easier to control than others. And
Right.
and is it odd or abnormal for someone who is still having a regular period to be having hot flashes at
It's
night?
it, it's not actually, and we don't necessarily know why that is. It could be a combination of estrogen and progesterone deficiency. We know it's more common in that week before the menstrual cycle starts, which does mean that it's a result of the rapid drop in estrogen and progesterone. But what happens in perimenopause, because of this disrupted feedback loop, that when we're premenopausal, it's this beautiful rise in estrogen and progesterone. They peak around ovulation and then come back down. And there's a predictable, fluctuation and small increase in FSH and then a big increase in LH right before ovulation. So now that we're perimenopausal, we don't always ovulate, and that can disrupt this sort of feedback loop. And our levels, I've seen levels in perimenopausal women of estrogen that are the same as women doing IVF, and I've seen levels in perimenopausal women that are having regular periods that are undetectable. So it just depends on where you catch them for the labs, and labs aren't always a necessary thing. In my practice, we do a fair amount of labs just because we all really like the data, and our patients frequently want to see their progression. They're seeing us year after year. And some of these patients I've seen since they were in their 20s and now they're in their 40s, and like you. And so we do more labs than, labs are not 100% necessary. They're not necessary at all, actually, for starting hormone replacement. And we don't treat to a particular number on the estrogen or progesterone. But some patients just kind of want the data on themselves to see how it changes over time.
It's interesting because I started having hot flashes and I had brain fog and major fatigue and panic attacks, which I had never had before. And this really got much worse after my hysterectomy that I had because of endometriosis. My ovaries were left intact. And as you said at the start of this, your ovaries are what make your hormones, right? Is that what you
The
said?
vast
The,
majority, yeah, the vast
okay. I mean,
majority of
the majority.
estrogen and progesterone are and testosterone are made from your ovaries.
So even though I kept them for whatever reason, I was still having these symptoms. And so for other women out there that are in their 40s and they've had it a hysterectomy and they're thinking, well, my hormones should be normal, quote, normal, and I shouldn't
Yeah,
be having these issues. I wanted to speak on that because you checked my hormones, and although they looked normal on paper, and I was sad at first because I thought I don't have an excuse to start hormones,
right,
because you are a certified menopause expert, right? You have a certification from the Menopause Society,
right.
and you are a fierce advocate for women not suffering. You knew well enough to know, no, we're not just looking at your labs, we're looking at your life and the fact that if you don't have a uterus, you don't have to worry about bleeding. So there are a lot of
And
women
also,
in the
what's the harm in trying it? Try
yeah.
it for 2 or 3 months. It might actually make you feel better, or it doesn't, and we just stop it and we think about doing something else. You know, with how low risk it is to use menopause hormone treatment, especially in perimenopause. So the amount that we would increase your estrogen level with an estrogen patch is minuscule compared to what your ovaries can pump out in one of those irregular cycles. One of the coolest, not coolest, it's miserable when people have it, I guess, but one of the more interesting things that we encounter in patients in perimenopause are loop cycles. They're called luteal out of phase cycles. And it's a cycle where your brain tells your ovary to ovulate. The ovary makes a nice follicle and that's producing lots of estrogen, but it doesn't actually ovulate. So then maybe a week or so later, the brain says, "Hey, we didn't ovulate. Let's ovulate," and it makes another one. And it stacks that estrogen production on top of the previous estrogen production. And estrogen levels can go as high as like 800, 1,000, over 1,000. Whereas, normally in the beginning of a cycle, it's like 20. So these huge fluctuate. And I mean, of course, you're going to feel that, right? Like, how could you
Oh,
not? How could you
rage.
not? Yeah.
Rage. Or just
Breasts
major.
are big and tender and they're very moody and, just really, and then they get this dysfunctional bleeding as a result of it too. And I think and for those patients, menopause hormone therapy is not going to lower the chances of having loop cycles. Birth control is what suppresses those types of cycles because it suppresses the attempt at ovulation that our body's trying to make. So sometimes birth control is the best option for someone for perimenopause hormone replacement. And so it definitely deserves a discussion and a lot of patients are really surprised to hear that.
Know that someone like that would require a much higher dose of hormone therapy, which would be closer to the combo pill. And someone needs to be on estrogen and progesterone if they have a uterus, correct?
Right. So estrogen therapy alone is reserved for people that either have a progesterone IUD, a Mirena specifically, a levo or Liletta, a levonorgestrel IUD, or they've had a hysterectomy. So estrogen stimulates our uterine lining and it stimulates it to grow and thicken in a normal menstrual cycle. Estrogen is the key behind thickening up the lining so that an embryo can implant there and we can have a pregnancy. But if we're giving estrogen to a uterus that doesn't have that normal cycling going on, then we could cause abnormal growth in the lining of the uterus, like hyperplasia, or even uterine cancer, if we're not balancing it with the thinning effect of progesterone. So progesterone thins the lining of the uterus.
So if you have a
Yeah.
uterus, you need estrogen and progesterone in
Or an
some,
IUD.
or
Hmm.
an IUD.
Yeah.
And I think there's a lot of confusion and fear around hormones and breast cancer,
Yeah.
especially when most women think that what they're going to die from is cancer. I'm guilty of that too, even though I worked in cardiology as a nurse
Mhm.
practitioner, and I know the number one killer in women is heart disease. I
The
s-
number one killer in women with breast cancer is heart disease.
I mean, the
It
number one
is.
killer in women with breast cancer is heart disease. Like,
Right.
let that sink in. It's
90% of
one.
us, 90% of us survive our breast cancer diagnosis. And it's great because it's very common. 1 in 8 will get breast cancer. And it's come a long way with early detection. We have more sensitive imaging modalities now, so we catch breast cancer much earlier, and there's more awareness around it. So, and the advent of genetic testing to look for genetic disorders that increase a patient's risk of breast cancer, doing risk reducing surgery, and encouraging patients to live a healthy lifestyle, because smoking increases the risk of breast cancer tenfold more than hormone replacement does. Drinking 2 glasses of wine a day increases the risk of breast cancer more than hormone replacement therapy does. I know, I still do it too. But but I get my breast cancer screening and I try and do it in moderation, but it's there are a lot of things that increase our risk of breast cancer that are much more significantly increasing our risk of breast cancer than hormone replacement therapy does.
So, what if someone came to you though and they have a first degree relative, a mom or a sister
Hmm.
with breast cancer, a hormone receptor positive breast
Right.
cancer, and they want
So
to?
those patients, I really have to spend some time getting the history of the family member that was affected. So if the patient's sister or mom, a first degree relative, had breast cancer, I would want to know what type. And the biggest thing I want to know is, did they have genetic testing? Because if they did and they're BRCA positive or one of the other 20 something genes that increases our risk of breast cancer, I need to get that patient tested, because she may need to have different breast cancer screening with mammogram alternating with MRI every 6 months instead of the typical yearly screening mammogram. So we do kind of that risk assess. I do that risk assessment, get the history, and then I calculate her thyrocusic score based on what I know. And that takes into account the BRCA status of her or family members, and breastfeeding and the age you were at your first period and things like that. If and so if that patient, and this is kind of an aside not related to hormone replacement, just breast health, but if that patient has a greater than 20% lifetime chance of breast cancer, she's considered at increased risk. And patients at increased risk probably need to get supplemental screening with either ultrasound or MRI
An MRI.
to increase the chances that we'll detect a small early breast cancer when it happens. For instance, my thyrocusic breast cancer risk is right at 20%. So I just kind of treat myself like I'm, 20%, and I do the supplemental screening
And by supplemental, you said it's an ultrasound follow up
or MRI.
or an
Hmm.
MRI,
Yeah,
right? And I think there are going to be a number of women who hear this and have seen many younger women, and rightfully so. The media has really shared
yeah,
their stories to spread awareness to prevent breast cancer. But I think in my mind, what ends up happening is you hear these stories of someone who had no family history,
right.
they're in their 30s, they get breast cancer. And that is a fear that lives in my mind. And what I was told by a radiologist whenever they found a mass on my mammogram and I was scared and I said I'm on hormone like all the things, right? Like you
Hmm.
hear that over the years that hormones, which we know now is not true, that hormone therapy does not increase your risk of breast cancer. But when they find a mass and you're on it, you blame yourself. That's where my mind went. And I
Hmm.
remember lying there while he's doing my ultrasound and him, before he found the mass, literally saying word for word, hormone therapy does not increase your risk of breast cancer, but what ends up happening is if you have a cancer there, it could maybe make it grow a little bit faster. And
Yeah.
so women have then associated the fact that it got, anyway, mine was not that, it was a cyst, but I found that to be very comforting, and he was very reassuring in that it is so protective for your heart, your bones, for your quality of life when you're older, that there is really no reason to not take it if your main fear is breast
Yeah.
cancer.
Well, it's just hard because just like a lot of things in medicine, you have to weigh the benefits with the risk. There is risk to every single thing that we do and every single medicine that we give. A patient could have a really terrible reaction to ibuprofen or Tylenol or, anesthesia when they have a surgery or whatever. So, it's just important to make sure that we set up the expectation that, hey, I don't know how you're going to necessarily respond to this, or I know this isn't increasing your risk of breast cancer, but it's just important that you know it could contribute in some way to it growing faster. But it doesn't impact overall survival rates or anything like that.
So it might make it grow faster if the cancer is already present when you started the hormone therapy, but it wouldn't have caused it, which is very different. Okay, so what type of screening or monitoring is recommended for women who are on hormone therapy, hormone
Mhm.
replacement therapy, and it's been a conversation with their doctor where maybe they are at a little bit of an increased risk for breast
Mhm.
cancer. Maybe that's through their family history. Maybe they have the gene present, or they have done the scoring and they know that they're at 20%, but they say,
Yeah.
well, for my quality of life, I want to do it, right? What
Yeah.
addition, and does it matter what type of hormone therapy they're on?
It does. So that's what we call shared decision making. I see my job as the physician to kind of break down all of the information that's out there in the data and present all of the treatment options that are available, kind of like a buffet. Here's the buffet of options that we have for you for treating hormone irregularities. Here are the pros and cons of each one. What seems right for you, at least for right now? You're coming back in a few months. We can always make a change if we need to, but what seems to achieve the goals that you have right now the best? And we try that, and sometimes we have to make changes, and sometimes they're feeling amazing on it, and we just keep on moving. But it is, and there aren't any really, well, there are a couple of studies on this, but it appears that the what we consider, and the word bioidentical always kind of gets on my nerves because it's not a medical term. It's just kind of thrown around out there, especially in like the health influencer wellness space, but patients understand it and patients say it to me. So I usually break it down between, okay, bioidentical means we are giving estradiol, the molecule that our ovary makes, and we're giving micronized progesterone, which is identical to the molecule that our body makes. So bioidentical just means it's the same molecule no matter where it's coming from, whether it's coming from a plant source or it's coming from, other ways that we yams or whatever, however we get estradiol. But that doesn't mean that it's necessarily better or controls that person's symptoms better. But generally speaking, estradiol and micronized progesterone have the lowest risk of breast cancer, and there are several studies that show no increased risk. Whereas what patients consider the synthetic hormones, like ethinyl estradiol and medroxyprogesterone acetate or norethindrone, do carry a slightly increased risk of breast cancer on the order of about an extra case of breast cancer per, like, it goes up from 4 in 1,000 women to 5 in 1,000 women. And when we're looking at, millions and millions of women having bothersome symptoms of menopause and all of the benefits of being on hormone replacement, really to me, that doesn't seem like a very significant reason to withhold it from someone. So, I definitely wouldn't recommend a patient take hormone replacement that's not willing to do breast cancer screening. So if a patient is not willing to get a mammogram and or an ultrasound or a breast MRI, I think I need to look out for the entire patient's well-being, and I need them to know how important routine screening is. And if it would feel irresponsible of me to give them something that could even a little bit increase their risk and not be watching out for any of those adverse outcomes that can happen in the future.
Even to me though, that seems so small as someone that always thinks, well, it could be me.
Hmm.
One in a thousand seems, and not even really
Yeah, I
one
mean,
in.
I just don't think when you compare the benefits that it's that significant.
No,
Someone else
because
might think it's very significant. You know, everybody
right.
is entitled to how they want to interpret that data. And the way that it was interpreted at the time the Women's Health Initiative study came out almost 25 years ago was that it increased risk by 25%. And that is what set off this massive firestorm against hormone replacement. And everybody said that it caused cancer. It's actually that data comes from the Women's Health Initiative study, but the way that it was presented and the way the media took off with it was really misleading. So
So we
and
know
I
that's
think
not true. We
we
know
know
that
that's
that's not
not
true.
true.
Okay.
Yeah, and the patient population, I mean, the one of the biggest flaws in the Women's Health Initiative study was that their primary endpoint was supposed to be for cardiovascular disease, and they also gave conjugated equine estrogen or ethinyl estradiol and medroxyprogesterone acetate to women who weren't even symptomatic in menopause. They were just randomized to this treatment, and the average age of the women in that study was in their 60s. Most of them were 10 years after menopause, not in that safe window to start it. So extrapolating that data to women who are in their late 40s or early 50s, like it's a completely different data set. Those women are already at increased risk of breast cancer because of their age, and they're already at increased risk of cardiovascular disease because of their age. So it's difficult to use that study to, I think we got a lot of good information about the safety of hormone replacement therapy from it, but we also got a lot of, misconceptions, misinformation, and disinformation from it too.
Is that the study that caused a lot of physicians to take their patients off of hormone therapy?
Yes.
Okay. And that's what sort of scared everyone to death. And
Yeah. Well,
so,
no doctor wants to give a patient a medicine that gives them cancer. I
or
mean,
what they
that,
thought, or what they thought. Because if
yeah,
someone hears this clip, what she's
yeah.
saying is it was not the case.
We were
This
worried. Yeah, people worried, oh my gosh, I'm causing harm doing this. Nobody was trying to withhold treatment from women.
right.
Everybody was actually really scared that, wait, it actually increases risk of breast cancer. Breast cancer is already really common. We don't want that. But it just that data just wasn't presented in an appropriate way, really, and it was extrapolated to women that were much younger.
So what we know is that hormone therapy does not put you at an increased risk for breast cancer. And if
And if it does,
anything,
it's very small, and it depends on the
okay.
type of
So if
hormone
it does,
replacement.
it's very small, possibly insignificant. And the benefit, because like you said, nothing in medicine is black and white, and
Right.
everything is pros and cons. So the pro for hormone therapy is that it protects you from fractures, which we know in women that are over 70, if you have a fracture, your risk of dying the next year is 25%.
Right.
Okay. So we know that hormone therapy protects your bones, protects you from dying from a fracture. It
Hmm.
protects you from, possibly protects you from Alzheimer's.
Right. There's some early, it's tough to do studies on cognitive decline.
I can imagine.
Especially as it relates to hormone replacement therapy, and have them be, easy to validate and things like that. But it makes sense that it would, but there's really nothing conclusive on that. We do know that if you started in that, what we consider kind of a safe window before the age of 60 or within 10 years of going through menopause, that patients patients risk of a major cardiac event decreases by close to half. But if you
Half.
start it after age 60, there's no benefit. So
Oh, right.
there's something that happens in that perimenopause to menopause transition as a
Mhm.
result of the fluctuating hormone levels, and then the eventual cessation of production of those hormones, that it's almost like a switch. Like all these different things, people become more insulin resistant. People are more likely to develop things like heart disease, diabetes, all these different things, and we're still just starting to evaluate that more and collect more data on it.
So a woman's risk of heart disease is decreased by taking hormone therapy. And if they withhold the hormone therapy from themselves, maybe out of fear from what we have learned from social media, that this false accusation that it causes breast cancer, they're more likely to die of a heart attack than they were ever going to be at risk for breast cancer from the
Right.
hormones. Okay. So we can settle women's minds with that,
Yeah.
because I think that it's very prevalent to hear these really horrific stories of young women getting breast cancer, where it's
Yes.
scaring women to the point where they don't want to protect what is actually probably going to, quote, as you said, take them out later in life, a heart attack, a
Yeah,
stroke.
yeah, the things that are really going to be life limiting as we get older. And nobody wants to live for the last 10 years of their life in a nursing home or being unable to function or not able to take care of themselves. And so if we can start some really good habits and we take care of ourselves and we do all the other things, is really heart disease has a lot of modifiable risk factors, right? There are five big ones. We've got the patient's body mass index. So the more overweight or obese a patient is, the higher their risk of heart disease. There's systolic blood pressure. So if your blood pressure, and the guidelines for that changed not too long ago, you probably know more about this than I do, but a normal blood pressure is now 135 for systolic or less. It's no longer 140. That has an impact on risk of heart disease, and that's modifiable. Like if you go on blood pressure medicine or get your weight down and deal with your blood pressure with lifestyle. The third is high cholesterol. So the non-HDL cholesterol. HDL is considered the good cholesterol. Having high non-HDL cholesterol. And then the two biggest ones are smoking and diabetes. So there are five solid modifiable risk factors for heart disease. And I don't know that our culture in the United States does a really great job of assessing and addressing those. And we can get into we'll do a whole separate podcast on weight and GLP-1s at some point. But GLP-1s have now emerged as one of the ways to decrease the risk of a major cardiovascular event in the future. And I think it's really exciting that we have a medication that is so effective.
I've heard.
There's something like 25 to 30 new GLP-1s that are in RDI, like in the drug development phases at different phases. There are pills that you take twice a week. There are pills that you take every day. There are new types of medications that induce natural GLP production. So, going kind of a step back and increasing the amount of GLP that our bodies make on their own. So, I do think these are going to be like supplements at some point. We're just not quite there yet. But right now, for high risk patients, they are life changing and life saving. 100% life changing and life saving.
So for women who choose to not take hormones, is there
Mhm.
anything natural that they can do? I know you talked about stress management, working out, all the
Right.
things. What about supplements, and does exercise and diet changes actually help go through menopause?
Yeah, they definitely do. So there are some women for various reasons who are not good candidates for hormone replacement therapy. And for those people, there are a lot of options for non-hormonal options for treating the bothersome symptoms of menopause. One is lifestyle modifications. So, a reduced sugar diet, like a less inflammatory diet, has been shown to decrease hot flashes, reduction in caffeine, alcohol. increased exercise decreases the number of hot flashes. There are hypnotherapies that can decrease hot flashes. We encourage patients to dress in layers. There are those like neck cooling fans that they can do to treat their hot flashes. But honestly, if you're having 20 hot flashes a day, I don't know that I'd probably bother with that. But everybody's different with what they want to do. Um, and then the pharmacologic options, there's actually a hypnosis app that people can get. I think it's called Evia, EVIA, that is a hypnosis for hot flashes. Um, and then the pharmacologic options are using antidepressants like Effexor can decrease the frequency and severity of hot flashes. And help with some of the anxiety and mood changes. Effexor or venlafaxine is an anti-anxiety medication. And now there are two newer medications called neurokinin 3 receptor agonists that work in our temperature sensor in our brain to decrease hot flashes. They're called Veoza and Linquet. Linquet was just approved and became available a couple weeks ago. It's very, very, very new. But those are a daily pill that patients take, and within a week, their hot flashes are significantly improved. It's a
Wow.
non-hormonal treatment. Veoza or fezolinetant, that had a couple of issues with liver function abnormalities in their phase 3 trials. And so we have to check liver function tests at baseline, at month 1, 2, 3, 6, and at a year to make sure that a patient's liver function tests don't become abnormal. And then the second one that came out recently, elinzanetant, we still have to check LFTs, but it's a less frequent interval. And elinzanetant has excellent it has emerged as an excellent treatment for sleep disturbance too. So not only does elinzanetant help with the patient's hot flashes, but it also improves their sleep,
Which is major. For me, that was
which
the
is
first
major.
thing. 2
Yeah,
a.m., like clockwork. I didn't even have to
right.
look at the clock. I
Yep.
knew I was up.
Wake and awake for an hour or two.
Mhm. Sweating, soaked, like I'm talking, I had
Yep.
to and I was 39. I had to change the sheets every day, soaked, like
Yeah.
through the mattress
It's
pad, like
awful. It's
not
awful.
normal. You know how you sweat so much that you, and women can relate to this, I know, or men who have had the flu, and you sweat so much that you're freezing. You
Mm-hmm.
wake up and you're freezing, but
Oh
you
yeah.
are anyway. So yes, that is horrible for women to have to go through that. So as a
Yeah,
women's
I
health,
think yeah, I think one of the many misconceptions around menopause hormone therapy, there are several that come to mind. One is that it's always contraindicated in patients with a history of breast cancer. There are certain cases in which you can use hormone replacement therapy after you have had treatment for breast cancer. That, again, is a very nuanced discussion between me and the oncologist and the patient about risks and benefits, but there are a lot of patients that are able to do that. The second is that all forms of menopause hormone therapy have the same risk. We know that transdermal estrogen that's absorbed through the skin, whether it's a patch, a gel, or a vaginal ring, does not increase the risk of stroke, DVT, or deep vein thrombosis and pulmonary embolism, or PE. So, but the oral versions do, regardless of what type. Oral estradiol carries the same risk as conjugated equine estrogens or like the synthetic types of estrogen. So we typically try to do transdermal because we know it decreases that risk. Um, the third thing is that hormones are the only effective treatment for menopause symptoms. They're not. We have plenty of other treatments we can do. We just went through a list of those. Um, the other is that vaginal estrogen carries the same risk as hormone replacement. This one can be confusing for patients, so I want to be really clear about it. So there is a type of hormone replacement that is a vaginal ring that is absorbed systemically and treats hot flashes. There is also a vaginal ring that only treats the vagina, and they have very close names. One is femring and one is e-string. And so it can be very I know, right? It can be very confusing for patients because if a patient say she has a blood clotting disorder, for various reasons we can't put her on systemic or full body estrogen. She can safely use vaginal estrogen cream, vaginal estrogen tablets, inserts, or that estring or e-string for the symptoms, the genitourinary symptoms of menopause safely. Those are not absorbed systemically, but there but there is a vaginal ring that is also absorbed systemically. So you just have to be clear about what you're getting.
And that would treat just locally, the vaginal dryness. Women that have gone through this will
Right.
know my
Yes.
phone's about to die.
Oh, okay.
So, okay. So if you could leave listeners with one message about hormone replacement therapy and menopause, what
Oh
would it be?
gosh. Oh, there are very few people that are not candidates for it. And there is a huge need for doctors, nurse practitioners, PAs to be comfortable with prescribing it because so many women that are candidates for it do not have access to it right now. So I think that's the biggest thing is that yes, you're probably a candidate for it. Yes, you need someone experienced in prescribing it that then follows you closely to make sure you're getting the desired response.
And because people that, even women that live in Charlotte, have a hard time getting in with you because you are booked out,
Right.
you are busy, booked and busy. So you told me
Well,
that,
people see the need for it, right? Like my
yes,
practice is one of very few of its kind, and we're the largest menopause practice in the Southeast. So we have 5 doctors and 8 nurse practitioners, and we still can't meet the need. And
no,
there are other practices within Charlotte. Novant has a menopause practice. Atrium has a menopause practice. Femwell is a practice in South Charlotte. Everybody, like we have a lot of people trying to provide this care and get it out there. It is not a competition between us. It is drinking from a fire hose. All of us
yeah,
drinking from
it's
a fire
just
hose.
divide and conquer. So if women
Yeah.
outside of Charlotte even or inside and they can't get an appointment, uh, are looking to help themselves, which this is the reason we're doing this, go to menopause.org and there is a list. Dr. Hauschka's on there, Jennie Hauschka's on there. These are women that have done the extra certification
And
in,
men, and men. We
no,
have
I'm
lots of
sorry, I'm
we have
sorry.
lots of male menopause certified. Chris Morris, my partner, is one of the best. He's
How
one of the
dare
best.
I? How
Yes,
dare
do
I?
not. Do
I
not.
have before you, well, Dr. Stepp is is also an OBGYN,
Right.
right? So, okay,
Hmm.
I have a male OBGYN, and before I met you, I had Dr. Tibble. I'm crazy right now because
No, no, no. It's okay. It's okay.
we're
I
in
just
the
don't
world
want you
of
to get
women.
messages afterward. The people are like, oh, I have to see
I
a
don't
woman.
think yeah. Okay, so go to menopause.org, find a provider that will help you. And if you simultaneously want to get help while you're waiting on an appointment with those people, there are virtual menopause clinics likely that
Right.
are on that list. And you can get an appointment. This is not something you have to be in person for because this
Right.
is clearly a long convo. And we are going to continue this conversation. There's a lot to cover. So we're going to talk about all the things because without women being healthy and functioning, the world will crumble.
That is probably the thing that you should post.
Okay.
That is the basis of the whole episode. If we're
Okay.
not taking care of women in the appropriate way and actually treating them for perimenopause and menopause, which is very disruptive for most people, like what are we doing? Like we can't keep this world going.
No,
We got to take
because
care. The other thing is that, like, what I always tell patients too, when they say things like, and you can cut this out later, but when they say things like, well, you're the first doctor that's ever listened to me, or nobody has ever told me that I could do the hormone replacement or whatever. I'm like, you know what? I'm sorry, but we girls got to take care of each other, man. You
yes,
know?
because you know what it's like to be in the trenches. I think that moms get a lot of support right after they have the baby. How are you? How's the baby? Maybe not all the time. And a lot of times it is how's the baby, but not how are you? And then and maybe girls whenever they're just like starting their periods. There's a lot of like,
We have all the puberty classes and puberty
yeah,
books and all these different things. Yeah, I
like
would argue
everyone
that
handles.
perimenopause is like going through puberty backward. It's terrible.
It is
It's
crazy, and
terrible.
it's like we need someone to handle us with kid gloves. And there's I will say this, the idea of going through menopause is not glamorous or commercialized, right? Like you
Right.
see all the like cute tampon boxes, all the cute, baby
Mhm.
stuff and this and that. But when you go through menopause, I remember seeing women that were going through menopause and talking to their friends about it and crying because it feels like such a bad time in your life. But for me, it's been really
It's
freeing.
just the beginning.
It's just the
Like
beginning. And
these are the years where we should be like blowing it out, right? I
I
mean,
feel the
we're
best.
financially stable now. We're in a good
Yes.
place in our career. We have a great partner, hopefully. We have kids that may leave our house at some point in the next decade. Like it would be really nice to feel good too.
Yeah. I will say, and this would be my message for going through this early.
Yeah.
I feel the best that I have ever felt when I'm on this, like you said, a hormone therapy for menopause, perimenopause is a lower dose. It's not
Yeah.
like the high dose because I took birth control pills too to control my endometriosis, and they, because you were there with me, I did not do well on them. They were
No, you
horrible.
did not.
I felt horrible. I was
I remember it well. Yeah, you did
like
not feel
put
good.
put it as an allergy, like I can't
Mhm.
handle it. So I was petrified to go through menopause because I had my uterus removed because of endometriosis. I was able to take this lower dose of hormone therapy. So my message for women is that I feel the best that I have ever felt, and it's because I found, or I have, a doctor who knows about menopause. So find a doctor. And you
Yes.
might have to switch doctors. You have to advocate for
I
yourself
mean, I
because
even have patients that just come to our practice to manage their hormones, and they keep seeing the person that delivered their babies and have their pap smears with them and catch up with them on a yearly basis.
I
That's
love that.
fine. But
I
if
love
that
that.
person is not someone who's willing to sit and talk to you about your symptoms and offer you all the treatment options, then you find someone who will.
And I don't think that that other doctor will care because not
No, they
everybody
don't
can't
because
be
they
good
don't
at
want to deal with
everything.
it. Believe me, they don't want to hear all your symptoms and deal with it. I promise.
Everybody can't be good at everything. And
Right.
so it's okay to advocate for yourself. You're not going to hurt anyone's feelings because women have
Mhm.
to feel good to make the world go round. And so we're going to be back. This is just our first real episode, okay? So listen on your drive to work, doing carpool, doing all the things because as women, we don't have time to sift through all the information. So we're just going to clarify some things and we hope this helped. Dr. Hauschka, thank you.
Thanks for
Amazing.
having me. We'll do it again. We're
We're
going
going
to
to do
keep
it,
going until we get through all the information.
which is going to be just every day, just every day.
Pretty much, I guess. Yeah.
All
Yeah.
right, come back, guys. Thank
All
you.
right.